The mediastinum. When we look at nomina anatomica, we can see the definition of the mediastinum as a septum that is interposed between the two lungs. It is limited cephalically by the thoracic inlet and caudally by the diaphragm. It is a septum that has an anterior border, the sternum, and posteriorly the ventral aspect of the thoracic vertebral column. In this diagram of the mediastinum, we see that the heart is the central structure that divides the mediastinum into an anterior, middle, and posterior. In other words, any mass projecting ventral to the heart and ventral to the trachea is in the anterior mediastinum, which is subsequently subdivided into an anterior superior mediastinum, the home, for example, of the substernal thyroid and thymus, and the precardiac, which is the anterior inferior aspect of the mediastinum. At the level of the heart, in the area of the trachea, we have adenopathies, which are next to the heart, the most common masses that we see in the middle mediastinum. And behind the heart and behind the posterior wall of the trachea and in front of the thoracic vertebral column, we have the posterior mediastinum. In many textbooks, the paraspinal regions are classified as part of the posterior mediastinum. We do not consider the paraspinal regions posterior mediastinum, and we will describe masses in that location as paraspinal or paravertebral. This is an anatomic coronal section of the paraspinal region. Note that there is right pleural effusion. We placed T in the pleural cavity, and you can see a nice meniscus sign of pleural effusion. Note that the right lung comes against the spine, while the left lung is separated by fibroadipose tissue. When we see fibroadipose tissue to the left of the spine, we get a paraspinal line distinctly seen on frontal views of the chest. However, in most patients, the right lung abuts against the right margin of the thoracic vertebral column, and we do not identify a right paraspinal line. This is a diagram which shows to your left two lines to the left of the spine. The medial one represents the left paraspinal line, and the lateral one represents the lateral wall of the descending aorta. In the slide under B, one can see only one left paraspinal line, which represents the lateral margin of the descending aorta. In the diagram B, the patient did not have fibroadipose tissue, therefore the left paraspinal line is not identified. In the diagram number C, we see no lines to the left of the midline except the proximal portion of the descending aorta. And in such a situation, the aorta descends in the ventral aspect of the thoracic spine, and therefore we do not identify the aortic line. In this patient, we can identify the right paraspinal line because of the presence of osteophytes. When there are osteophytes, the medial aspect of the right lung does not contact the lateral margin of the vertebral bodies, and therefore it can be distinctly demonstrated. This is a frontal chest rentgenogram of a patient with left subpulmonic effusion. Note the density interposed between the aerated lung and the fundus of the stomach. Where could that density be? It could be above the diaphragm, it could be arising from the diaphragm, or it could be subdiaphragmatic. We can be sure that this is a supradiaphragmatic subpulmonic effusion by the following signs. Laterally, we note the blurring of the left cosodiaphragmatic angle. We also note that we do not see distinctly the sharp margin of a convex left dome of the diaphragm. We also note that markings cannot be seen through this density. And finally, we can see a lateral displacement of the lowermost portion of the left paraspinal line. This is indicative of a cephalic ascent of the fluid. Whenever we see this constellation of findings, we can be sure that we're dealing with the subpulmonic effusion. The lateral displacement of the left paraspinal line is another sign of a subpulmonic effusion. Note that this patient also has a density in the left juxtahilar region. The patient had a bronchial carcinoma which was non-resectable. In this patient, there is bilaterally displaced paraspinal lines. Note that the vertebral column is radiographically intact. Whenever we see such an abnormality, we must differentiate fluid collection, fat, mesenchymal abnormalities, and tumor. The patient had a lymphoma, and these masses represent paraspinal adenopathies. Similarly, in this patient, we see laterally displaced paraspinal lines. However, note the destruction of the disc spaces and also of vertebral bodies. We can therefore suspect that the primary disease was in the thoracic vertebral column. In this case, this was tuberculosis or Pott's disease, and the paraspinal densities represent the paraspinal abscesses. In this patient, we note a focally displaced left paraspinal line. Note that to the left of the midline, we see the two lines, the one that corresponds to the left paraspinal region, and the other one that corresponds to the left margin of the descending aorta. It is the left paraspinal line that appears displaced laterally by a mass. This mass does not displace the esophagus. Therefore, it is not in the posterior mediastinum, but in the left paraspinal region. The most common tumor in this location is a neurogenic tumor, which can be benign, like a ganglioneuroma or neuroilemoma or even neurofibromas, or can be malignant, like sympathicoblastomas, or can be a combination of benign and malignant neurogenic tissue. In this patient, there was a neuroilemoma in this location. In this infant, we note a displacement of the trachea ventrally and a mass that projects behind the shadow of the heart and thymus. Therefore, the location of this mass is in the left paraspinal as well as the posterior mediastinal regions. This is an example of a neuroblastoma. Again, the most common tumor of the left paraspinal region and is a neurogenic tumor, which can be either benign or malignant. This is a patient that has bilateral paraspinal lobulated densities. Could this be adenopathy? So the answer is yes. However, this patient had an enlarged liver, an enlarged spleen, anemia. So this is a case of extramedullary hematopoiesis. This is another patient with widened mediastinum due to masses in the paraspinal region. Here, the extramedullary hematopoiesis extended along the thoracic vertebral column. In the lateral view of the previous patient, we note that the paraspinal masses are poorly visualized. Whenever we have a paraspinal mass, the lateral view of the chest may be deceptive. It is therefore important to penetrate the frontal view of the chest enough to see the paraspinal region. Note the focal extramedullary hematopoiesis in this coronal MR image of the chest. The density of these masses is the same as the density within the vertebral bodies, and this helps us identify the nature of the tissue. The similarity of densities and with the proper clinical history, we can then suspect extramedullary hematopoiesis. Other indirect findings are retroperitoneal pathology and abnormalities of the liver, spleen, masses in the paralumbar regions, etc. When diagnosing a paraspinal mass, particularly if the mass is bilaterally located, we have to inquire in the history of the patient. If the patient has severe anemia, myeloid metaplasia, hyperparathyroidism, rickets, leukemia, lymphoma, carcinomatosis, polycythemia vera. Some patients with pneumonia, B12, and folate deficiencies are all causes of extramedullary hematopoiesis. This is a rare cause of a paraspinal mass. Note the density that we know in the frontal view is not in the plane of the heart because we can appreciate distinctly the left ventricular contour. When we see the lateral view of the chest, we confirm the paraspinal location of this mass. Differential diagnosis, a tumor, particularly neurogenic, but remember that any connective tissue mass can simulate a neoplasia of neurogenic or epithelial tissue. In this case, this is an example of aggressive fibromatosis, a rare condition that can present as focal masses in the retroperitoneum as well as in the paraspinal region. This is a tomograph of the same pathology showing a well-circumscribed mass in the left paraspinal region. Note that the mass does not contact the thoracic vertebral column. This would make it unlikely to be extramedullary hematopoiesis, which is an entity that generally affects the two sides of the spinal column, and the masses abut the vertebra. Note also that there is a thickening of the pleura posteriorly. This is an anatomical cross-section at the level of the shoulders. Note the right lung to your left and the left lung to your right. In front of the spine, we see a ring-like structure that represents the esophagus, and ventral to it, we see the trachea. Behind the esophagus is the collapsed azygos vein, and also the thoracic duct is in this anatomical location. Between the esophagus and the spine, the two lungs come in contact, and they form radiographically what is called the posterior junction line. The posterior junction line, as we shall see later, is a structure behind the esophagus, in front of the thoracic spine, above the arch of the aorta, and diverges cephalad, forming a letter Y. And displacement of the posterior junction line, or the absence of this structure, indicates or may indicate the presence of a mass in the posterior mediastinum above the arch of the aorta, between the esophagus and the thoracic spine. This is a coronal and lateral diagram that I obtained thanks to Dr. Tony Proto, which shows the junction of the two lungs above the arch of the aorta, and limited superiorly by the anterior aspect of the thoracic inlet. This is the posterior junction line, which would be several centimeters in length, and again demarcated by the arch of the aorta inferiorly. Note that cephalically it branches, so the appearance of this region would be the appearance of a letter Y. In the lateral view of the chest, the anterior portion of the posterior junction line is always behind the esophagus. The posterior junction line is appreciated in this close-up of the upper mediastinum. Note the medial convexity of the two lungs that come in contact with each other. When we note this in a radiograph, we know that we are looking at a region of the posterior mediastinum between the esophagus and the thoracic vertebral column. This is a patient who had high blood pressure, and that explains the enlargement of the left ventricle. The lungs were free of infiltrates. If we look at this radiograph quickly, we may miss the pathology that exists at the level of the posterior mediastinum. Note that the medial aspect of the right lung, instead of being convex medially, it is slightly concave medially. And we also see a similar abnormality in the medial aspect of the left lung. In other words, the fact that we do not see the Y-shaped posterior junction line suggests that this patient may have a mass in the posterior superior mediastinum. This patient had back pain. In the lateral view of the chest, at first glance, we may consider it negative. However, Note that in front of the thoracic vertebral column, close to the thoracic inlet, we see a density that is convex anteriorly. This patient proved to have a monilial abscess, and this was proven by needle aspiration. So the only abnormality noted in this frontal and lateral view of the chest was an abnormality that affected the posterior junction line and precisely located the pathology in the posterior mediastinum behind the esophagus above the plane of the aortic arch. This is a horizontal section of the chest. Note the right lung that projects in front of the thoracic vertebral column. This is an anatomical region that has been described as the crista pulmonis. The lung touches the right wall of the azygos vein, the right wall of the esophagus. And because the mediastinal pleura contacts these structures, this air soft tissue interface noted in frontal view of the chest has been called the pleuro-azygoesophageal line. It is not a line, it is a plane. Any abnormality that would enlarge the azygos vein, that would enlarge the esophagus, the descending aorta, or masses behind the trachea will displace laterally the pleuro-azygoesophageal line. This anatomical section was obtained at the level of the tracheal bifurcation, so the binocular-like structure that we see represents the right and the left main stem bronchus. Note that this line is formed by the medial projection of the right lower lobe. The major fissure is distinctly seen separating the right upper lobe from the right lower lobe. This is a frontal chest rentgenogram where we can see the pleuro-azygoesophageal line extending from the tracheal bifurcation all the way down to the diaphragm. It may be seen in the midline as a straight line, or it can be slightly shifted to the left of the midline. It can be straight or can be mildly convex or concave towards the left side. Any disappearance of this line or displacement of this structure would place a lesion in the posterior mediastinum behind the cardiovascular structures. This is an example of a patient where we can see the lateral displacement of the inferior portion of the paraspinal line. The mass that we note behind the heart is due to a hiatal hernia. Note that the mass also extends to the left of the midline and is noted medial to the left heart border. The most common anatomical structure that displaces the pleuro-azygoesophageal line is the fundus of the stomach. So one can recognize on frontal view, say, hiatal hernia, not just by the presence of air above the diaphragm, but by the demonstration of a mass, and particularly the lateral displacement of the right paraspinal line. The diagnosis of a hiatal hernia is confirmed in the lateral view of the chest. Note that we do not see the posterior heart border because it is silhouetted by a mass that is interposed between the heart and the diaphragm. Note that the mass extends beyond the posterior outline of the heart, so it cannot be due to the heart, and particularly it has an air fluid level. Note also that we do not see the bubble of the stomach below the diaphragm because the stomach is in the chest. So these findings are pathognomonic of a sliding hiatal hernia. In this patient, we note what appears to be an enlarged cardiac silhouette. However, it is unlikely to be the heart due to the fact that we do not see a distinct separation between the right atrium and the superior vena cava. So the right cardiomediastinal border is not characteristic of a normal superior vena cava and a normal right atrium. We also note that there is no evidence of the pleuro-azygoesophageal line. The lungs are free of infiltrates and the heart does not appear to be enlarged. Whenever we lose the pleuro-azygoesophageal line and there is a widening of the mediastinum, we should always obtain a lateral view of the chest and particularly consider an esophagogram. An esophagogram was obtained in this patient, and note the massive dilatation of the thoracic esophagus would retain food in its upper portion. This was a patient with Chagas disease. Chagas disease is a common infectious process in certain parts of the world, particularly in equatorial Brazil. And the dilated esophagus could also have been caused by achalasia, and less likely an obstructing lesion in the distal portion of the esophagus. Again, a clue that this was the esophagus and not the heart was the morphology of the cardiomediastinal silhouette and the lack of visualization of the pleuroacic esophageal line. In this child, we note a tubular density behind the heart. Note that we do not see the pleuroacic esophageal line. This tubular density is outlined by arrowheads. In the lateral view, although we don't have a barium in the esophagus, we note a ventral displacement of the trachea. A soft tissue density is noted between the thoracic vertebral column and the trachea. So the lesion is in the posterior mediastinum. And this proved to be another example of a dilated esophagus, in this case due to achalasia. The esophagogram of this patient shows a diffusely enlarged esophagus with retained secretions. This adult individual had a history of progressive dysphagia, first to solids, then to liquids. He also had considerable weight loss. With that history and the radiographic findings, we must suspect an advanced cancer of the esophagus. In the frontal chest rentgenogram, we note a laterally displaced lower portion of the pleuroacic esophageal line. We note that the bubble of the stomach is below the diaphragm, so this is not an example of a hiatal hernia. Because the paraspinal line is displaced laterally from a dilated esophagus or a mass arising from the wall of the esophagus, with the proper clinical history, we had to suspect that this was a case of a tumor arising from the distal esophagus. This is the esophagogram of the previous case, where what we can see smooth narrowing of the distal third of the esophagus. Note a paraesophageal density that anatomically represented a mass extending lateral to the esophagus. This proved to be an unresectable cancer of the thoracic esophagus. Displacement of the esophagus dorsally and of the pleuroacido-esophageal line in its superior portion can be the result of enlargement or displacement of the left atrium. It can be the result of a mass in the posterior mediastinum, such as a bronchogenic cyst or subcarinal adenopathies. That will be the most common group of entities in the differential diagnosis of a laterally displaced superior portion of the pleuroacic esophageal line. To your left, note that the heart is not enlarged. We observe a double density in the middle of the heart, which produces a second arch in the right cardiac contour, a bulging middle third of the left heart border, inferiorly by the left auricular appendage and superiorly by a prominent pulmonary trunk, and also note the prominent hyla with redistribution of blood to the upper zones. These are classic findings of mitral stenosis. Also note that the aortic knob is small in size. In the lateral view of the chest with a barium swallow, we can see increase in the AP diameter of the heart with increase in the surface contact of the heart with the sternum due to enlargement of the right ventricle. And we note a focally displaced esophagus due to the dorsal displacement and enlargement of the left atrium. Note that the left ventricle is not enlarged. So these are classic findings of mitral stenosis. Also, we note ventral to the esophagus prominence of the hilus superiorly, but we do not see prominent vessels inferior to the hilus. This is the result of redistribution of blood flow when a patient develops a pulmonary hypertension secondary to mitral stenosis. This patient had shortness of breath and dry cough. The frontal chest rentgenograms revealed indistinct parenchymal densities bilaterally. But also we can see widening of the superior mediastinum to the right of the trachea. We then have to suspect the possibility of paratracheal adenopathies. Note that we do not see the pleuroascicosophageal line from the tracheal bifurcation to the diaphragm. The superior portion of the pleuroascicosophageal line is displaced laterally, and we do not see in the left heart border abnormalities that might suggest a prominent left auricular appendage or prominent pulmonary trunk. So the fact that we suspect a mediastinal component should narrow the differential diagnosis of the non-specific chest abnormalities in the lungs to granulomatous disease or to tumor. The patient had the biopsy-proven sarcoidosis. Following treatment with steroids, we note the resolution of the parenchymal densities. We also note disappearance of the paratracheal mass as well as the subcarinal adenopathies. The displaced pleuroascicosophageal line in this patient was due to enlarged subcarinal nodes. In this frontal view of the chest, we note surgical clips in the left hilus, and we also observe a lateral displacement of the pleuroascicosophageal line superiorly. Although we do not recognize a mass, we must suspect the possibility of subcarinal adenopathies. There is slight widening of the interbronchial angle with slight cephalic displacement of the right main stem bronchus. This patient had a history of melanoma and proved to have at autopsy enlarged subcarinal nodes. We do not need to see a mass to diagnose subcarinal adenopathies. Simply the displacement of the pleuroascicosophageal line will locate the pathology to the retrocardiac region, in other words, the posterior mediastinum, and the differential diagnosis therefore should include enlarged left atrium, bronchogenic cyst, and adenopathies. In the absence of cardiac abnormalities, adenopathies would be the best bet. And in this case, metastatic melanoma had to be diagnosed. In this coronal tomogram of the previous patient, we note distinctly the subcarinal mass and note the lateral displacement of the superior portion of the pleuroascicosophageal line. The surgical clips are again observed, again a patient with metastatic melanoma to the subcarinal region. This patient had also a density in the posterior mediastinum displacing the lung to the right, that is the pleuroascicosophageal line. And in the lateral view, we note focal displacement of the thoracic esophagus. So again, this is a case of mitral disease with an enlarged left atrium. The larger the left atrium, the greater the chance that we may be dealing with mitral insufficiency rather than with mitral stenosis. In this patient, we might think that the left atrium is displacing the esophagus, like in the previous case. However, there was no history of cardiac disease, and therefore the enlarged left atrium had to be considered not a likely possibility. By computer tomography and magnetic resonance imaging, this proved to be a case of a foregut duplication cyst, in this case a bronchogenic cyst. So in the differential diagnosis of retrocardiac masses, an enlarged left atrium, adenopathies, and bronchogenic cysts should be considered on top of the list. A cast corrosion preparation with a section that was obtained at the level of the trachea. We can see to the right of the trachea a vascular arch that represents the arch of the ascus vein. To the left of the trachea, we see two arches. The superior one represents the transverse portion of the thoracic aorta, and the inferior arch represents the left pulmonary artery. Note the yellow material that appears interposed between all the mediastinal structures and represents the mediastinal fat. Because of mediastinal fat, we can readily recognize the vascular structures of the mediastinum, and also note that the right pulmonary artery appears caudal to the left pulmonary artery. Below the pulmonary artery, we see the left atrium with the left ventricle to the left and inferior to the left atrium. In this patient, we note a density to the right of the tracheobronchial angle. Otherwise, the chest is radiographically normal. This density could represent a vascular structure or a mass or a cyst and less likely localized fluid collection. We note also a tubular density that extends towards the diaphragm, and we do not recognize the pleuroascicosophageal line. So the continuity of this density with the tubular structure behind the heart suggests that we're dealing with an enlarged ascicus vein. The simplest way of differentiating an enlarged ascicus vein from adenopathy is to fluoroscope the patient or to compare a supine with an upright view of the chest. This is the supine view of the chest of the previous case, where we can see distinctly an enlargement of the mass in the right tracheobronchial region. And we can also see the density behind the heart, so therefore we are dealing with an enlarged ascicus vein. The right femoral vein was punctured and contrast was injected to opacify the right side of the heart. Note that instead of seeing the inferior vena cava, we note the tubular structure that ascends in the chest and opacifies the right tracheobronchial region. This represents the ascicus vein that terminates in the right atrium. The tubular density that displays the pleuroascicosophageal line represented the dilated ascicus vein in the chest. This is an example of ascicus continuation of the inferior vena cava, which is the result of a genesis or marked narrowing of the inferior vena cava, the hepatic segment of this structure. This is the lateral angio of the same patient, which confirms the dilated ascicus vein and the dilated ascicus arch, which courses from left to right and from back to front and terminates in the right atrium. It rides in the right tracheobronchial angle, and therefore, when enlarged, it produces a density that can simulate a vascular structure, including a double aortic arch, or can represent a mass. The ascicus vein, when dilated, can represent a tumor in the tracheobronchial region. The criteria to determine if the ascicus arch is normal or enlarged is that its maximum transverse diameter should be less than 7 millimeter. Dr. Felsen considered that in the upright position, the maximum transverse diameter should never exceed 10 millimeters, so that is 1 centimeter. And Dr. Robert Fraser believed that in the supine position, it should not exceed 1.4 centimeters. The criteria to determine if the ascicus vein is enlarged should be the presence of a prominent ascicus arch in the frontal view of the chest and the possibility of seeing a tubular density behind the heart which displaces the pleuroascicosophageal line and represents an enlarged vein. And that paraspinal tubular density represents the enlarged ascicus vein, particularly seen in the entity called ascicus continuation of the inferior vena cava. In the lateral view of the chest, the enlarged ascicus vein in patients who have ascicus continuation of the inferior vena cava shows indistinct posterior wall of the left atrium, the presence of a pre-spinal vertical line which represents the anterior wall of the ascicus vein, and an inferior vena cava density that either is absent according to Heller, or it has a vertical or posterior course according to Folger. Normally, the terminal part of the inferior vena cava produces a posteriorly concave line just above the diaphragm. When that line is vertical or convex posteriorly, or is not seen in deep inspiration, this may be indicative that we do not have a normal inferior vena cava and that the patient may have ascicus continuation of the inferior vena cava. An enlarged ascicus arch may be the result of increased resistance to the emptying in the superior vena cava, or of the superior vena cava flow restricted at its entrance into the right atrium. It could also be due to increased blood flow in the ascicus vein, as seen with ascicus continuation of the inferior vena cava. It can be the results of trauma or be idiopathic. Increased resistance to the emptying of blood from the ascicus vein to the superior vena cava to the right atrium is observed when there is obstruction of the superior vena cava between the terminal portion of the azygos vein, that is the azygos arch, and the right atrium. There could be a right atrial hypertension, as seen in congestive heart failure, cor pulmonale, or tricuspid insufficiency. Or there may be resistant to the emptying of blood from the superior vena cava into the right atrium, as seen with pericardial effusion or with pericardial constriction. Another mechanism that will explain enlargement of the azygos arch is when there is absolute increase in the blood flow in the azygos vein. This can be the result of a congenital or acquired obstruction of the inferior vena cava. The congenital forms include failure of fusion of the caudal segment of the hepatic inferior vena cava with the pre-renal inferior vena cava, or due to a hypoplastic hepatic inferior vena cava. There can also be acquired obstructions of the inferior vena cava, as seen from thrombosis or tumor. Portal hypertension can be another cause. Superior vena cava obstruction above the azygos arch, resulting in flow diversion of veins that normally terminate in the superior vena cava, now emptying into the azygos system. There can be also an anomalous pulmonary venous connection, where the pulmonary vein to azygos or to the hemiazygos vein is observed. Pregnancy that has an absolute increase in blood volume, and arteriovenous fistula can also lead to a prominent azygos arch. Causes of azygos vein enlargement include portal obstruction with esophageal varices, that is flow diversion from the abdominal veins into systemic veins that terminate in the azygos system. Congestive heart failure, tricuspid insufficiency, constrictive pericarditis, pericardial effusion, superior vena cava obstruction, inferior vena cava obstruction, congenital absence of the inferior vena cava, so-called azygos continuation, and idiopathic forms. The differential diagnosis of enlarged azygos arch includes a mass lesion in the right tracheobronchial angle that could be represented by an azygos node, such as a lymphoma, metastatic disease to the azygos node, and the presence of a cyst or of a tumor. Also, a vascular lesion can mimic an enlarged azygos arch, and that would include a right aortic arch, the so-called three arches sign, and an enlarged superior vena cava with or without anomalous pulmonary venous connection, and there are about 48 variants of anomalous pulmonary venous connection according to Snellen. The significance of observing an enlarged azygos arch is that for the diagnosis of certain conditions, this is important. For example, if a person has a pulmonary embolism, the chances are that right heart hypertension will result in an enlarged azygos arch. If a patient has a chest pain and is not related to pulmonary embolism, there is no reason to expect an enlarged azygos arch. In patients with constrictive pericarditis, likewise, the diagnosis is not always easily made because only 50% of patients have a quiet, calcified small heart. If there is no calcification at the level of the pericardium or the heart is enlarged, an enlarged azygos arch may indicate the presence of constrictive pericarditis with constriction at the level of the right atrioventricular groove. Abnormal situs is another situation that the azygos continuation of the inferior vena cava helps to determine what type of abnormal situs is present. And sometimes in the studies of congenital heart disease, such as ASDs and common atrium, an enlarged azygos vein is important in the differential diagnosis and in the recognition of certain forms of congenital heart disease. Finally, the treatment significance of an enlarged azygos arch is that in cardiopulmonary bypasses, the position of the cannula is critical when there is a very large azygos vein. When performing a Glenn procedure, which is the anastomosis of the superior vena cava to the right pulmonary artery, and this is done whenever there is a congenital obstruction to pulmonary blood flow at the level of the valve or beyond the valve, the presence of a large azygos arch can pose technical problems. Also, when trying to insert an umbrella filter from the jugular vein down into the inferior vena cava, if there is no inferior vena cava, then this technique will be impossible. This is a photograph of the right hilus, where we can see to the left the spine, and the heart will be to your right. The tubular structure that rides above the right main bronchus represents the azygos arch. Note that between the azygos arch and the superior vena cava, we note bluish material in the azygos node. This represents the anthracotic pigment in the azygos node. Also note the anatomic proximity between the azygos vein inferiorly and the azygos node superiorly. Below the arch of the azygos vein is the right main bronchus. And below the right main bronchus, we also see anthracotic pigment in subcarinal lymph nodes. This patient shows calcific deposits in a mass that sits in the right tracheobronchial angle. This would make it pathognomonic to calcified azygos node. The patient had a history of tuberculosis. Note also calcified granulomas in the upper lobes. In the lateral view of the chest of the same patient, note the calcified azygos node, an elliptic structure that is bisected by the anterior wall of the trachea. So we can see its posterior margin by the lung in the supraazygos recess. Note in this patient that the heart and lungs are radiographically unremarkable, but that we see a small density in the right tracheobronchial region. One has to suspect the possibility of adenopathies when such a finding is observed. This patient had a history of lymphoma, and a gallium scan was ordered. Note the intense uptake in cervical nodes, supraclavicular nodes, and in mediastinal nodes. So this confirms that the density seen in the radiograph of the chest was related to enlarged nodes. It is amazing that enlarged mediastinal nodes may not cast an abnormality on frontal chest rentgenogram or show minimal abnormalities such as displacement of air soft tissue interfaces. We generally see more in CT and MRI of the mediastinum than on chest rentgenograms, and certainly we can see many more adenopathies if we use nuclear medicine examinations such as gallium scans of the patient. Note in this patient to your left a density to the right of the trachea. This could be a double aortic arch, it could be an enlarged azygos vein, it could be an enlarged node. We can see in the lateral view of the chest to your right that the supraazygos recess shows a mass that is bisected by the anterior wall of the trachea. The rounded configuration of this mass and the fact that it has a posterior margin and it is cephalad from the azygos arch makes an enlarged azygos node. The patient had a microcytic carcinoma of the lung, so-called oat cell carcinoma, and this represents metastasis to the azygos node from the bronchogenic carcinoma. In this other patient, we see a subtle density in the lung, labeled as M, which was a tumor, and note also a prominence of the azygos node due to adenopathy. So the distinction between an enlarged azygos node and an enlarged azygos vein is not only given by history, but also by the fact that particularly in the lateral view of the chest, when the node is not calcified, we should always see a posterior margin to the node, while there is no posterior margin in the azygos arch. We only see of the arch the superior margin and the inferior margin due to the recesses of the lung surrounding this anatomical structure. It is a rounded mass transected by the anterior wall of the trachea that appears rounded in configuration in the lateral view of the chest, what makes it the node and not the enlarged vein. In the differential diagnosis of tracheobronchial masses, the first differential diagnosis should be between vascular and non-vascular structures, particularly adenopathies. Sometimes adenopathies produce a large focal mass, as demonstrated in this frontal tomogram of the chest. of a patient who was asymptomatic. Note that the mass is rounded. It does not represent a right-sided aortic arch because we can see the descending aorta, and in the frontal view of the chest there was a distinctly seen aortic knob. So we have to consider adenopathies as the most common cause of such a mass. Other tumors such as enlarged thyroid or a mesenchymal tumor or an enlarged thymus could be considered as well. This is a coronal MR examination at the level of the tracheal bifurcation, where we note enlargement of subcarinal nodes and also enlargement of nodes in the right hilus, as outlined by the arrows. This patient had the same disease as the previous one. This is an axial MR image of the previous subcarinal mass, showing a high signal at the level of the mass. The diagnosis in this case was Castleman disease. Ben Castleman was an outstanding pathologist from Mass General Hospital in Boston, and he was the first to describe what he called a giant lymph node hyperplasia, and subsequently other names were given to the same entity, such as lymphoid hamartoma, angiomatous lymphoid hamartoma, follicular lymphoreticuloma, and benign giant lymphoma. Angiofollicular lymph node hyperplasia or Castleman disease is characterized histologically by hyperplastic lymphoid follicles with capillary proliferation and endothelial hyperplasia superficially resembling thymoma. This is a very hypervascular lesion that enhances when we do a computed tomography. When we biopsy the lesion, it can bleed, and when looking at the signal intensity on enhanced MR examination, we note the increase in the signal, which reflects the hypervascularity. Very few tumors are as hypervascular as lymphoid hamartoma or Castleman disease. When a hypervascular mass is noted in the mediastinum and we consider a tumor, we have to suspect the Castleman disease in the differential diagnosis. Carcinoids are other tumors that are very hypervascular and occasionally metastatic melanomas. Histological variants have been described, such as hyaline vascular and plasma cell. Systemic manifestations have been described with Castleman disease, and they include nephrotic syndrome, anemia, growth failure, peripheral neuropathy, fever, hyperglobulinemia, and hyperalbuminemia. Also, Castleman disease has been described in retroperitoneal and intra-abdominal lymph nodes. This is a microscopic section of a lymph node of a patient with Castleman disease. Note the hypervascularity and the benign appearance of the round cell infiltrate that surrounds the central portion of the lymph node. This has been classified also as lymphoid hamartoma, because often the remainder of the mass shows perfectly normal lymphoid tissue. So the entire mass doesn't have to show this type of pathology that we are seeing in this microscopic section. This is a coronal anatomical section where we injected a red plastic in the vascular tree. We note the right arch that represents the azygos vein, and two left arches that represent the one cephalically placed the transverse portion of the thoracic aorta, and the one below it, the arch of the left pulmonary artery. Note the yellow fat surrounding these mediastinal structures. This is a radiograph of the previous anatomical section. Note in white the vessels, the azygos vein in the right tracheobronchial angle, the transverse portion of the thoracic aorta giving off the left subclavian artery, and below it the bifurcation of the left pulmonary artery. Between the arch of the aorta and the pulmonary artery is an anatomical region that is called the aortic pulmonary window. This is a tomographic examination at the level of the trachea. On the left side, you note the radiolucent area that resembles a bow tie. And this is the bow tie sign of Dr. Heitzman that represents not air but fat between the arch of the aorta and the top of the left pulmonary artery. The inferior aspect of the aortic arch is depicted by the presence of calcium. A calcified plaque outlines the lower margin of the arch of the aorta. This is an anatomic section courtesy of Dr. Heitzman showing the arch of the aorta, and we note the ductus arteriosus that goes from the undersurface of the aorta to the top of the left pulmonary artery close to the pulmonary trunk. In the aortic pulmonary window, in addition to the ductus arteriosus and the fibrous remnants of the ductus, we have 2 to 4 lymph nodes, we have connective tissue, fat, and we also have nerves. This is the coma sign described also by Dr. Heitzman. Consists of a calcific tubular density extending from the undersurface of the aorta to the top of the left pulmonary artery. In patients where there is a ductus arteriosus that has become fibrotic, calcification of the ductus will produce the coma sign. The ductus node appears calcified in this patient. Note that it is projected at the level of the aortic pulmonary window, which is the structure between the undersurface of the arch of the aorta and the top of the left pulmonary artery. Normally, there are 2 to 4 lymph nodes in this location. A calcified node is usually the result of a healed inflammatory process such as tuberculosis or histoplasmosis. There are other causes of calcification, as we shall see in other lectures. This patient had a solitary pulmonary nodule which appears quite dense. Note that in the region of the aortic pulmonary window we see a slight convexity, which is outlined by the arrowhead. Whenever we see a pulmonary lesion and we note the fullness in the region of the hilus or at the level of the aortic pulmonary window, then the mass in the lung is most likely a cancer, and the cancer has already extended to the mediastinum. This proved to be a bronchial carcinoma, and the mass in the hilus proved to represent enlarged nodes in the region of the aortic pulmonary window. Another structure that can appear in this region is the veins that are surrounding the arch of the aorta, and this is in blue, the left superior intercostal vein. We can see this vein often tangentially, and it can produce what is called the aortic nipple. It can appear as a normal variant or become enlarged whenever there is obstruction of central veins. Tony Proto and Dr. Heitzman have provided this anatomical section. Also note that medial to the vein we see the left recurrent nerve. Lateral to the arch of the aorta we see a projection that represents the aortic nipple, and it represents a normally or an enlarged left superior intercostal vein. To the left, an aortic nipple, which proved to be an enlarged left superior intercostal vein, which was dilated as a result of an obstruction in the mediastinum. That obstruction can be the result of fibrosis, such as seen in histoplasmosis, or following irradiation of the mediastinum. A malignancy in the mediastinum can also block the systemic veins and dilate the left superior intercostal veins, producing a prominent aortic nipple. This is a hilar tomogram showing the branching of pulmonary arteries and pulmonary veins. Note that the oval density of a hilus is continued by tubular structures that merge with the outline of the density. This means that the density represents vascular structures. Note that the outline of the oval density shows concave contours. In the right hilus, we note that the oval density of the bifurcation of the right pulmonary artery and confluence of the right pulmonary veins does not project behind the trachea. And the reason is that the right pulmonary artery and the right pulmonary veins are ventral to the trachea. On the left side, the branching of the left pulmonary artery occurs dorsal to the trachea behind the left main bronchus. Therefore, a lateral tomogram of the left hilus may show a density behind the plane of the trachea. These are paratracheal and peribronchial lymph nodes. They're usually small. They occur usually at the bifurcations of the trachea and bronchi, and only become radiographically apparent when they exceed 1.5 to 2 centimeters in diameter. If a lymph node becomes rounded, we must suspect that it is a pathological node, particularly when it exceeds 2 centimeters in diameter. Another diagram which shows the anatomical location of lymph nodes as they relate to the branching of the left tracheobronchial structures. In this lateral tomogram, we note a mass in the region of the hilus. Note that the mass continues with very large vessels. The vessels that appear to merge with the outline of this mass are particularly seen in the upper and lowermost portion of this mass. This means that the mass is on a vascular basis, and this is a patient who had a left to right shunt, in which the prominence of the lower lobe vasculature exceeds that of the upper lobe vasculature. Whenever we have a left to right shunt, we see enlargement of the arteries and of the veins, which account for the enlarged hilar shadow. When dealing with adenopathies, we may see an enlarged hilar shadow, and we can recognize that the enlargement is not due to vessels because of several features. One, the splaying of the bronchi. Two, the possibility of compression of the bronchi. And three, because the outline of the mass is convex rather than concave. Finally, another criteria is that some of the density that we see projects beyond the posterior wall of the trachea, and only enlarged nodes will produce such a density when looking at the anatomical right hilus. So this is an example of hilar adenopathy. This is a representative radiograph of a bronchogram. Note that we also see contrast in the esophagus. The patient swallowed contrast material when the bronchogram was obtained. Note that we have 3 large lymph nodes that were removed and that indented the outline of the right main bronchus. The enlarged nodes were due to sarcoidosis. Enlarged nodes can obstruct, can deform, can compress the tracheobronchial tree. And in children, because of the small caliber of the airway and the softness of its wall, often atelectasis is a result of enlarged juxtabronchial lymph nodes. In this patient, the lateral tomogram shows several nodes with calcium, as indicated by the horizontal arrow. These adenopathies may be missed unless the nodes are larger than 2 centimeters or they are calcified, as in this case. The etiology has to be suspected to be either an inflammatory, usually infectious process, and less likely an irradiated mediastinum, as seen with any type of cancers, particularly lymphomas. Following irradiation, calcification of nodes can occur. Rarely, sarcoidosis and amyloidosis can produce calcified nodes. In this lateral tomogram, we note an adenopathy that displays a bronchus. This is one of the bronchial manifestations of enlarged nodes. In this patient, a left pneumonectomy was performed due to a bronchial cancer, and the radiograph to your left represents the lateral tomogram showing a prominent right pulmonary artery, which is now receiving the totality of the right ventricular output. Note that we see no masses dorsal to the trachea, and that the posterior wall of the bronchus intermedius, as indicated by the thick arrows, has a normal thickness. To your right, note the same patient several months later. Recurrence of the disease, enlarged mediastinal lymph nodes, and a large mass now surrounds the tracheobronchial tree. Note also that there is a thickening of the posterior wall of the bronchus intermedius, as indicated by the solid arrows. We also can see enlarged subcarinal lymph nodes, as demonstrated by the open arrows. This is a frontal rentgenogram of a patient who was asymptomatic. An abnormality was noted in topography of the middle segment of the left heart border. Could this represent an enlarged pulmonary trunk? Not likely, because we do not see pathology of the left pulmonary artery that projects behind this mass. The most common mass in this location is related to a thymic tumor, and this proved to be a thymoma. The home of the thymoma is in this area of the middle segment of the left heart border, usually at the same plane of the heart, and at the junction of the superior vena cava and right atrium. This is another middle mediastinal mass that is located exactly at the same plane of the heart, as we can see in the lateral view of the chest to your right, and also represented a thymic tumor, was also a thymoma. There is a minimal pleural effusion, blunting the left costal-diaphragmatic angle posteriorly. These are 6 images of a thymoma studied by coronal section. The first 5 and the bottom right is an axial view. Note the well-circumscribed mass, which projects next to the heart, occupying the middle segment of the left heart border. This is an MR study of the previous case of a benign thymic tumor, a thymoma. It is not possible by pathological examination and certainly not by imaging modalities to make the distinction between a malignant from a benign thymoma, unless we see features that indicate invasiveness. A well-circumscribed thymic mass can be either a benign or a malignant thymic tumor. Cardiomegaly in this patient can either be related to a dilated heart, to pericardial effusion, or to a combination of both. In patients with pericardial tamponade, the pulmonary vasculature appears decreased. But if the pulmonary vasculature appears normal, there is no way that by radiography we can separate pericardial effusion from cardiac dilatation. The signs of pericardial effusion will be demonstrated in the next few slides. This is a coronal anatomical section very close to the sternum. Note in yellow the fat that surrounds the heart and appears interposed between the aorta and the pulmonary trunk. Note a right pleuropericardial fat pad, which is seen between the lung, the dome of the diaphragm, and the right atrium. And on the left side, we can see a left pleuropericardial fat pad, which is a fat between the parietal pericardium and the mediastinal pleura. Note that the heart is surrounded by an envelope. We note along the left heart border cross sections and oblique sections of branches of the coronary arteries and of the coronary veins. Note that there is apposition of the two pericardial layers, which is noted lateral to these vessels, and we note lateral to the parietal pericardium fat. The fat between the visceral pericardium and the muscle is called the epicardial fat. And the fat between the parietal pericardium and the mediastinal pleura is called the mediastinal fat. When there is separation of the two layers of the pericardium, we may see a density that is water in appearance that is demarcated by the epicardial fat medially and the mediastinal fat laterally. Note in this close-up of the left heart border in the frontal projection a radiolucency that corresponds medially to the epicardial fat and laterally to the mediastinal fat. Note a thin water density envelope that represents the apposition of the visceral and parietal pericardium. In this lateral sagittal section, the spine is to your left, the anterior chest wall is to your right. Note the epicardial fat separated from the mediastinal fat by the pericardium, and the two layers of the pericardium are slightly separated, indicating that there is a space between these two layers of the pericardium. In this radiograph in the lateral projection, we can see a radiolucent band between the water density pericardium and the radiolucency that corresponds to the mediastinal fat in front of it. In other words, the pericardial stripe is an envelope that surrounds the heart and may be seen in very short exposures of the chest, and also it is distinctly observed if we see a prominence of both the epicardial and mediastinal fat pads. In this frontal projection of a heart that is enlarged, we see a thickened pericardial stripe. Note the arrowheads that show the epicardial fat. It is possible to suspect the pericardial effusion when the thickness of the pericardial stripe exceeds 1.5 or 2 millimeters. In this lateral view of the chest, we note a thick pericardial stripe. The arrowheads indicate the radiolucency of the epicardial fat, and the white arrow shows the thickened pericardial stripe. So plain radiography may be helpful in trying to differentiate cardiomegaly from pericardial effusion if we are lucky to see the pericardial stripes. The normal pericardial cavity contains very small amounts of fluid, which are not detectable by conventional radiography, but we can see pericardial fluid exquisitely by echocardiography. And this is a slide that shows to your left the anatomical sagittal appearance of the heart chambers, and you can also see to the right a tracing of an echocardiogram. On the top left and right we can see a normal heart, and note that there is a distinct echo in the posterior wall of the left ventricle. In the bottom diagram, an echocardiogram, we can see how the fluid collects in the dependent portion of the heart when a patient naturally is lying supine. And then you can see in the tracing of the echocardiogram an anechoic space that is represented superiorly by the pulsations of the left ventricle and inferiorly by the parietal pericardium. This is a sagittal echocardiogram showing the left ventricle below the right ventricle in front, and note that there is echogenicity from the posterior wall of the left ventricle and a hypoechoic area between the posterior wall of the left ventricle and the parietal pericardium. This is a pathognomonic of pericardial effusion. Note that the pericardium reflects at the level of the entrance of the inferior pulmonary veins. So the cephalic portion of the pericardium is inferior to the cephalic portion of the pericardial reflection. As we shall see later, the superior portion of the pericardium anteriorly reflects at the level of the takeoff of the brachiocephalic vessels. This is a classic echocardiogram which shows the hypoechoic areas below the pulsations of the left ventricle, and this was due to the collection of fluid in the dependent part of the pericardial cavity. There are several pitfalls in the diagnosis of a pericardial effusion. They include pulmonary disease, pleural effusion, pneumopericardium, myocardial hypertrophy, pericardial cysts, and pericardial tumors. Some tricks can be used to diagnose small pericardial effusions. One is to do a sagittal scanning, and this is what we see here. To the right of the midline, to your left is the head of the patient, to your right will be the feet of the patient. Note the echogenicity of the anterior wall of the inferior vena cava. That blends with the echogenicity of the inferior wall of the right atrium and right hemidiaphragm. In front of the inferior vena cava are the echoes of the liver. In this sagittal echocardiogram, we note a triangular anechoic space between the inferior wall of the right atrium and the echoes of the right diaphragmatic dome. PE indicates pericardial effusion. So this anechoic space is characteristic of a pericardial effusion. It may not be detectable if it appears to be loculated to the posterior aspect of the heart. HV represents hepatic veins, and the echoes below, that is to the right of the diaphragm, are the echoes of a normal liver. This is a lady who had a history of ovarian carcinoma, removed 18 years before this chest radiograph was obtained. Note the enlargement of the cardiac silhouette, and note the density above the left ventricle. The heart appears to contact the left chest wall. In the lateral view of the chest, we note enlargement of the heart, and the only dome of the diaphragm that we see is the right dome. There is a small left pleural effusion. This is a radionuclide angiocardiogram which shows a large photopenic area which represents the distended pericardial cavity, and the outer margin of this envelope shows nodularity, and the nodules were secondary to implants of tumor in the surface of the heart at the level of the parietal pericardium. So one of the contributions of scintigraphy is not only to detect pericardial effusions, although we recognize that echocardiography is more sensitive, but sometimes to establish the possible cause of the pericardial effusion. When we see nodularity along the pericardial cavity, we have to suspect the implants of a tumor. This slide indicates the incidence of some cardiac metastasis. Melanoma is 30 to 65%, bronchial carcinoma 21 to 37%, lymphoma 13 to 35%, breast cancer 25 to 33%, and soft tissue sarcomas 25%. The complementary role of scintigraphic examination with echocardiography is illustrated in two cases. This first one shows evidence of pericardial effusion by echocardiography, but when we injected a radionuclide compound, we can see the inside of the heart, and we note that the radioisotope, when it arrives to the left side of the heart, shows a focal bulge at the level of the left ventricle. So actually we are dealing with a left ventricular aneurysm. So knowing that the patient had a pericardial effusion and knowing that the patient has a left ventricular aneurysm, the most likely possibility of the acute pericardial effusion was a leaking left ventricular aneurysm that was readily detected by radionuclide examination. This next case also shows pericardial effusion by echocardiography. However, the intravenous injection of a radionuclide shows a holdup in a dilated left innominate vein and superior vena cava. And there is a relative narrowing at the junction of the superior vena cava with the right atrium, as indicated by the arrow. Whenever we see this, this is indicative of either metastasis to the right side of the heart or to constrictive pericarditis. This patient had a history of a bronchial carcinoma, so therefore we have to suspect the metastasis causing this narrowing. If the patient did not have a lung lesion, then we would have to suspect the constrictive pericarditis. In the scintigraphic image in the bottom to right, we note the anechoic area that represented the pericardial effusion. Gallium scintigraphy of the heart should show no uptake in a normal heart as indicated to your left. On the right side, we note a technetium flow study which shows the hypoechoic area surrounding the heart between the radioactivity inside the heart and the radioactivity in the lung. And this is a characteristic of pericardial effusion. But in radionuclide studies, we do not see the subtleties of pericardial effusion that can be revealed by echocardiography. This is an example of how can computed tomography help in recognizing pericardial effusion. Note the thick band surrounding the heart, and this thick band represents the fluid in the pericardial cavity. Incidental finding in this patient is the presence of bilateral pleural effusions that can be readily seen in the dependent part of the right and left hemithorax. This 38-year-old woman had a history of smoking and presented with chest pain and slight shortness of breath. Note a peculiar bulge of the left heart contour, and also note that it appears indistinct, and there is a suggestion of a cavity at the junction of the superior aspect of what could be the left ventricle and the middle segment of the heart. This is indicative of pathology in the topography of the lingula, and this could be a cavitary process. A frontal tomogram of the same patient shows several ring-like lucencies in topography of the lingula. This proved to be an example of cancer of the lung. It could have been an infectious process as well. Gallium scintigraphy showed intense activity at the level of the heart. This means that either there is a neoplastic involvement of the heart or that this could be an infectious process. Because of the history of smoking, we suspected a cancer which was proven at the time of autopsy. So gallium can help in differentiating benign pericardial effusion such as transudates from inflammatory or infectious processes or even neoplasias that may involve the heart. In this patient, we note an enlarged cardiomediastinal shadow. Could this be cardiac dilatation, pericardial effusion, a combination of both, or a tumor wrapping around the heart? Note that the aortic knob is not distinctly seen, and there is a suggestion that the widened mediastinum extends above the plane of the arch of the aorta. This would make this prominent mediastinal shadow a juxtapericardial and juxtacardiac tumor, that is, tumor wrapping around the heart and extending cephalad from the superior insertion of the pericardium, which is at the takeoff of the brachiocephalic arteries. A CT of this patient showed that there was a tumor wrapping around the heart, encasing the right pulmonary artery and producing the enlarged mediastinal shadow. That tumor extended above the aorta, and it turned out to be due to a lymphoma. This patient had the chest pain, and radiographic examination of the chest showed an apparent enlargement of the heart and evidence of a left pleural effusion. MR study revealed that the outflow tract of the right ventricle appeared narrowed, and a mass was noted medial and lateral to the pericardial stripe and also lateral to the right atrium. Another coronal MR view revealed a large mass encasing the proximal right pulmonary artery. At autopsy, this turned out to be a malignant lymphoma, and therefore the enlargement of the heart was not due to cardiac dilatation or pericardial effusion, but to a tumor that surrounded and invaded the heart. When I was a resident in radiology at the University of Pennsylvania, in my assignment to the Children's Hospital of Philadelphia under Dr. John Hope, we ran across this newborn who was born with a murmur. The plain radiograph of the chest showed what I interpreted as an enlarged heart, and I thought that the convexity seen in the right hemithorax represented the outline of the left ventricle. Note that we see air under the right dome of the diaphragm and that we see a water density under the left dome. So my impression was that we were dealing with a situs inversus universalis, and the baby had a dextrocardia with some sort of a congenital heart disease that did not become radiographically apparent. Dr. John Hope asked me if I had examined the baby, which I said no, and when I did a physical, I noted that the baby had a scaphoid abdomen. Whenever there is a scaphoid abdomen, we must suspect one or two mechanisms. One is the absence of air due to a high atresia, for example, duodenal atresia with or without annular pancreas, or a high jejunal atresia. And the second possibility is the presence of a diaphragmatic hernia. In other words, the bowel, with or without solid organs, can herniate into the chest, and the baby will end up with a scaphoid abdomen. So when I reported this to Dr. Hope, then he said, well, I don't believe that this baby has a diaphragmatic hernia, and certainly the baby does not have a bowel atresia, so something very unusual is happening in the mediastinum. And an angiocardiogram then was ordered. The angiocardiogram revealed that the left ventricle was in its usual location, that is to the left of the midline, that the heart was not the prominent shadow that we saw on plain x-rays. The heart was sitting on top of a large mass, and that mass represented a herniated liver through a defect in the tendinous portion of the diaphragm. In other words, the absence of a tendinous portion of the diaphragm made the liver grow in the chest, and therefore the heart was riding on top of the liver. Note that the baby had swallowed air, and now we can see that the stomach is in its usual position under the left dome of the diaphragm. The simultaneous opacification of the arch of the aorta and of the pulmonary trunk was an expression of a patent ductus arteriosus. So this is again to show that not every apparent cardiomegaly is due to an enlarged heart. This is an unusual case where the water density heart and the water density liver were indicative of a mass, and we could not separate one from the other on plain x-rays. And the clinical clue that the baby had a scaphoid abdomen pointed towards the possibility of a central herniation of an intra-abdominal organ, in this case the liver, in the chest. This is a normal frontal chest röntgenogram of an 18-year-old athlete. A year later, she presented with an apparent enlargement of the heart with left pleural effusion. She was water skiing in Miami, and the diagnosis was of a possible pulmonary embolism. At first glance, the enlargement of the heart shadow was not appreciated until we could compare this study with the immediate previous one taken a year before. A lateral chest röntgenogram shows that there is a left pleural effusion. Note also fullness of the retrosternal space. In view of this latter finding, the diagnosis of a possible mediastinal tumor was entertained. A pulmonary angiogram was performed looking for pulmonary embolism. In the upper lobes, note that there is obstruction to the flow and there is also encasement of the proximal right pulmonary artery. This latter finding would be against a simple case of pulmonary embolism. An angiogram was ordered and showed hypoperfusion of the upper lobes, but the striking finding was the mass surrounding the heart. Note that at the level of the aortic arch, the mass is lateral to the arch and extends above the arch. So consequently, the enlarged cardiac shadow was not due to the heart. It was also not related to the pericardium, but to a mediastinal tumor. At surgery, this proved to be a mesenchyma. Some called it undifferentiated tumor of the thymic gland. What is important is to recognize that an apparent enlargement of the heart can be simulated by a mass wrapping around the heart.